The last speaker, Professor Walter Ageno, Professor of Internal Medicine in Subri University, Varese, small clots with large impact.
Well, thank you. First of all, I would really like to thank Professor Fabbri for inviting me here to this beautiful meeting. It's my pleasure to discuss the small clots. I will, of course, focus on clots that affect the pulmonary arteries. And I will start by presenting the first epidemiologic data from Italy. This is the first epidemiologic study that was published last year. We published this study using populations from two regions in northwestern Italy, Piedmont, and Lombardy, which have about 15 million inhabitants. And the results of this study substantially confirmed what was reported from the United States a few years before. That is that the incidence of pulmonary embolism is clearly increasing over time. We look at the 10 years window between 2002 and 2012. And you can really see this trend, which may have different explanations, being of course, our improved skills in diagnosing the disease. Probably we think of pulmonary embolism as a diagnostic possibility more than we used to. And also, there is an increasing trend in diagnosis that are incidental. So the number of incidentally detected clots is also increasing. And I think this also reflects the other finding, that is the reduction in short-term mortality after pulmonary embolism. I think the data are quite clear here. We are certainly doing a better job in treating these patients, but probably we're also diagnosing lower risk pulmonary emboli more frequently, but we can discuss about that. Of course, these short mortality rates remain absolutely not negligible, and they are the expression of a very important spectrum, a wide spectrum of presentations. As Professor Celli mentioned yesterday, all patients look different, and this is very true for pulmonary embolism as well. So we can face patients who have a very high risk of early mortality, more than 30%, because they usually present with sustained hypotension or shock. But then we have the large majority of patients who have a very heterogeneous risk of early mortality that can be lower than 1%, but that can be also near to 20 or 30%. So our first goal really is to understand how our patient looks like and what is his short-term mortality risk. And this is really the first goal we do have. So the clinical presentation is extremely important. Of course, if we have a patient presenting with shock or sustained hypotension, he clearly is, or she clearly is, a patient at high risk of mortality. And of course, this presentation immediately drives our therapeutic decision toward reperfusion with thrombolytic as the first option, and then other more invasive options if necessary. But the problem remains with the large majority of patients who luckily present in hemodynamically stable conditions, and in this case we really have to use other tools. What do we know now, and what should we do now? Well, we have two options that can be combined. One is the use of markers of right ventricular dysfunction and of myocardial injury. Each of the markers that are reported here are significantly associated with an increased risk of short-term mortality. Right ventricular dilation measured by echocardiography, and also measured by using the same CT scan that led us to the diagnosis of pulmonary embolism are associated with a poorer prognosis, or the measurement of a laboratory markers such as BNP, which is also associated with a worse prognosis. Marker of myocardial injury is, of course, troponin. Again, each of these markers are associated with prognosis. If combined, their predictive ability is further improved. So this is a way we can go. Another way is to use our clinical skills by our own gestalt, our own clinical judgment, or by using scores. I don't think we like scores too much, based at least on our observations, but this is the best known score for PE patients, the PASI score, which has also now a simplified version. And I think it's interesting to observe those items that are associated with a worse prognosis. And you see here, we include baseline characteristics, underlying diseases, including chronic lung disease, and the clinical presentation. All these items, when combined, are telling us that our patient may be at increased risk of mortality. So, for example, if we have a 75-year-old patient, male gender with chronic lung disease, certainly we have to be particularly careful with these patients. That's what the PASI score tells us. And so the European Society of Cardiology guidelines are telling us to stratify the patients according to their potential short-term risk of mortality as our first task by using these tools. So they have stratified the patients in 4 groups. The high-risk patient group is really defined simply by clinical presentation, shock or hypotension. You don't need to measure any other parameter. But then we have the majority of patients who fall here in the intermediate high risk, intermediate low risk, and the low risk groups. And what they suggest is, of course, all these patients are hemodynamically stable. What is suggested is to check the PASI score. So they recommend the use of the PASI score, either the original one that I just showed you or the simplified version. And if the PASI score is negative, actually, it is really has been shown to be associated with a very low risk of mortality. Negative PASI score patients have less than 1% risk of mortality, and we're talking about 25% of our PE patients. So it's quite an important tool to use. And if it is positive, then we should possibly use those markers of right ventricular dysfunction or myocardial injury to better understand how our patient looks like. Now, many colleagues ask the same question, that is, so what? Because in terms of patient management, the high-risk patients require reperfusion. All other patients usually require anticoagulation. So the question is, well, treatment does not change really among all the other groups. Well, the reason for this risk stratification is to leave a door open for thrombolysis in this intermediate high-risk patient group, and also to drive our management of the patient. So we should use this stratification to decide where to put our patient in the hospital. A more intensive observation for the first days may be recommended for these patients, but for the low-risk patients, we can really consider home treatment from the beginning, or a very short hospital stay. So it's really more about management. Thrombolysis in the intermediate high-risk patients, so a clinical presentation in a hemodynamically stable patient with markers of myocardial injury and right ventricular dysfunction combined was assessed in the PATO study, which was published about 2 years ago, a very important study that everyone was waiting for to understand if a more aggressive treatment should be offered to these patients who were randomized to standard of treatment, anticoagulant treatment, or thrombolysis with tenecteplase. But the results of the study did not support the routine use of thrombolysis for these intermediate high-risk patients, because although the primary outcome was reduced with the use of tenecteplase, with thrombolysis, There was no actually difference in all-cause mortality, which was, of course, the most important endpoint, and any benefit was certainly offset by a four-fold increased risk of major bleeding. And you see here the risk of strokes, and we talk about hemorrhagic strokes, most of the cases raised from 0.2 to 2.4%. So this was really not convincing for the use of thrombolysis in this intermediate high-risk population. In clinical practice, regardless of the clinical presentation, this large registry, international registry, show that about 1% of patients actually receive thrombolytics. You may see higher rates if you look at some cohorts that are probably a little bit biased because they are patients referred mostly to cardiology units. This is probably more a more representative population. Majority of patients receive low molecular weight heparin and then vitamin K antagonists. And what about the new oral anticoagulants, the direct oral anticoagulants for PE patients? We do have PE patients in all the major trials. The impression, as we can expect from phase 3 trials, is that the low-risk patients mostly were enrolled in these studies. In all studies, all the direct oral anticoagulants, rivaroxaban, apixaban, dabigatran, and edoxaban, were shown to be as effective as standard of treatment in PE patients with an improved safety profile, which was interesting. Only one study, the Hoxsey study with edoxaban, tried to apply the risk stratification to patients with PE. In this subgroup of patients with PE, all patients underwent the measurement of NT-proBNP, and patients with an increased NT-proBNP were observed. We just submitted these sub-analysis for publication, and I think the results are very interesting because we have two very similar population randomized to either standard of treatment or to the direct oral anticoagulant, and you can see that in this higher risk population, the risk of recurrence was reduced by half by the use of a direct oral anticoagulant. And we really could not find any explanation for this because the two populations were really similar. The quality of INR monitoring was good in the standard of treatment arm. So this is a very interesting finding that we can eventually discuss. How are the direct oral anticoagulants used in clinical practice? Well, not much, especially when given immediately as a single drug approach for pulmonary embolism patients, not yet. I think the learning curve is important for us clinicians. We are a little bit careful. We prefer to use these drugs for DVT patients. Majority of patients with PE still receive a few days of heparin before we switch to direct oral anticoagulants. It was the first phase 4 clinical trial that we published last December, the Xalia study, and the use for patients with PE, the use of standard anticoagulation was significantly higher than for rivaroxaban. Not only that, but doctors still prefer standard anticoagulation in more fragile patients. So there is really a learning curve, and we will learn more about the use on PE patients in the future. I will go to the second and last part very shortly of my talk because in the acute phase of the disease, our goal looking at the phenotype of the patient is really to try to understand who is at increased risk of mortality. But pulmonary embolism is not only an acute disease. Pulmonary embolism can be a chronic disease because as many as 40% of patients will recur over a 8 to 10 years period. So a very substantial proportion of patients will experience a recurrence. So this is why we have to think about PE as a chronic, not just an acute disease for many of our patients. Of course, recurrence rates are different according to the presence of or absence of some risk factors, and this is when understanding why pulmonary embolism occurred becomes important to determine the duration of secondary prevention. So the risk of recurrence is extremely low if the disease was caused by a major risk factor that is removed, such as surgery or a major trauma. It is low but not negligible in patients in whom the disease was provoked by a non-surgical risk factor, and these include those patients who develop pulmonary embolism after hospitalization for acute medical disease, for example, COPD, reexacerbation, or pneumonia, for instance, and these patients fall in this category. But still, we are classifying about 40% of our patients as having an unprovoked VTE, and in this patient the risk becomes quite substantial and even higher in patients with permanent risk factors such as cancer. What we have learned about the treatment of these patients has really not changed from 2001 when we published the WADIT study. We did the WADIT study first on DVT patients and then on PE patients, but the results were exactly the same, showing that after the first 3 months of treatment in patients with unprovoked venous thromboembolism, it doesn't really matter if you continue treatment for an additional 9 months up to 1 year, because as soon as the patient stops treatment, then there is a catch-up phenomenon. So in those high-risk patients, the treatment duration should not be a definite treatment duration. You should decide to treat this patient for a minimum period of time, which is 3 months, or to continue indefinitely, because as soon as you stop, those high-risk patients will recur. So it's not really a matter of any definite longer duration of treatment. And of course, when you continue treatment, you have to face an increased risk of bleeding because you're using anticoagulant drugs, and this is no surprise. And this has caused, especially for the management of these unprovoked patients, some uncertainty in the management of treatment, but not only for them. And if you look at clinical practice patterns, the approach of clinicians with regard to the duration of treatment remains extremely heterogeneous, which means that we are still confused about what we should do, because about half of the patients, regardless of the presence or absence of major risk factors, are treated for more than 1 year, and the others stop earlier. So it's still an unmet clinical need, in my opinion, and we are trying to understand what other markers, what other parameters we have that can drive our treatment decision. And there are a few that have been identified: severe thrombophilia, unfortunately male gender. Males have an increased risk of recurrence as compared to females, but in my opinion what really matters the most in those patients with a so-called unprovoked VTE is the presence of an underlying inflammation, which can be related to obesity or even the metabolic syndrome per se, or any other chronic inflammatory disease, so including those that you are managing in your clinical practice. In the presence of underlying chronic inflammatory disorders, my suggestion is to keep patients on treatment, possibly not with warfarin, as we heard before in some cases, but that should be, that's a very interesting observation, I would say. There are also some markers, such as D-dimer, that are under investigation. So I will come to an end. We have observed, as other colleagues in the United States, that the incidence of PE is certainly increasing, while the PE-related mortality is decreasing. Certainly we have improved our diagnostic strategies and our management strategies as well, but probably we're also diagnosing more low-risk PEs. Again, there is an increasing incidence of incidentally detected PEs, especially in some patient populations, such as patients with cancer. Risk stratification, extremely important to determine the short-term risk of mortality, extremely important to determine the long-term risk of recurrence. Again, always think of PE as a chronic disease and not just as an acute disorder. Thank you for your attention.
Thank you, Walter. The discussion is open. Any question?
Thank you very much for your presentation.
Oh.
There is one thing that is of interest, and we talked about that yesterday, is that this picture of a chronic, so-called silent pulmonary emboli that eventually present with pulmonary hypertension. I mean, can you tell us something about that? How often do we see that? When we should think about it and so on?
Yeah, thank you for your question. So chronically, not only recurrence as symptomatic recurrence is an issue, but also the development of chronic post-embolic, thromboembolic pulmonary hypertension is a possibility. Now, the incidence of this complication has been reported to vary between 1% and 4% in clinical studies. The 3.8% study published by Vittorio Pengo from Padua in the New England Journal of Medicine. I think this is a very important complication because it may require surgery, and so it can be extremely relevant and in the clinical point of view. And as you mentioned, one of the most, if not the most important risk factor has been shown to be the silent recurrence of PE. So the problem is that we have figures of symptomatic recurrences, but probably asymptomatic recurrences are even more. And when patients develop these asymptomatic recurrences, they are more prone to then develop hypertension because they are left untreated most of the times. And one of the populations that is at high risk of this complication is represented by patients with an autoimmune disease that is antiphospholipid antibody syndrome. They are really prone to these continuous asymptomatic recurrences. So thank you very much for these comments.
Yeah, Walter, on the same line, you certainly remember the paper by the Lille group, the Lille Bond, looking for thromboembolism in people with exacerbation of COPD, not clear in nature, so undefined because of the clinical presentation. This is a rather frequent clinical picture. So the question is, what is the state of the art? What is your recommendation? I would like to have a simple tool without going into the CT scan, a simple tool to detect this discrete microembolism as potentially responsible for. I know that is the million question, but I know that each of us has this question. We do have this question. So what should we do? Be aggressive and just go to the CT scan whenever we have the idea, or?
I quote the sentence of Sam Goldhaber published a few years ago that to diagnose PE, you have to think of PE as a diagnostic possibility, which is something we don't do often. So I think the first step is really to consider that in a patient with sudden dyspnea, even if the patient has underlying chronic respiratory disease, PE is a possibility. And this is something we should take into account. But unfortunately, I don't have the simple tool you're asking me because in these patients, D-dimer is the first step for sure, because it may avoid us further diagnostic imaging. But the rate of positive D-dimers is higher than in the general population because they have a chronic inflammatory disease which is associated with higher levels of D-dimer. But I think it's always good to measure D-dimer. If D-dimer is negative, I think we can be a little bit more relaxed. VQ scan is not an option because the rate of false positive in these patients is too high. Intermediate diagnoses are too common. And so if our gestalt drives us to this suspicion, I think CT scan remains the only thing we can do. And these also answer this question because not doing that, the risk is that the patient accumulates recurrent emboli and then pulmonary hypertension becomes really an issue.
Thank you, Walter. Again, about chronic embolism, have you got any data about patient with chronic embolism and concomitant respiratory disorders, mainly COPD, in terms of morbidity or survival?
So the question is?
Is a sort of subgroup of patients with chronic embolism and concomitant respiratory disorder, mainly COPD.
I don't think there are really good data to follow up these specific population. I think this is an area where we should really work. And I think one problem is, as Professor Fabri mentioned, the fact that maybe we misdiagnose a number of recurrences. Whether this impacts the outcome, the long-term prognosis of patients with chronic respiratory diseases, I'm sure yes, it does. But to prevent that, I go back to what I said in my conclusions. These are patients that, unless contraindicated, I would definitely keep on treatment, long-term secondary prevention. I would not consider stopping too easily these patients, treatment in these patients, unless they had a major provoking risk factors that is removed, such as surgery. But if the event was not related to surgery, these patients should be protected with anticoagulant drugs.
In your first slide, that's your data in Italy about the incidence of pulmonary emboli, is very interesting. I noticed that starting in 2002 or something like that, females had a much larger, or seemed to have a much larger incidence than males. And then as time went on, the females seem to be lower. Is that a matter of age? Is it a matter of a change in habits in females as far as maybe birth control pills or?
Yeah, so I did not show, for the sake of time, another slide which showed the curves, age-related and gender-related curves. There is not really a great difference. The incidence is slightly higher in the very elderly population in females, but probably because they survive more, I think. We have always thought that there is a higher incidence of these events in young females because of gender-specific risk factors, namely pregnancy and even more oral contraceptives. So young females are exposed to more typical risk factors, but the curves do not really show a substantial difference, probably related to the fact that at young age the incidence is so low that the difference is not detected.
Thank you, Walter.
Thank you.
Leo? It's closed. Thank you for your participation and attention. The session is closed.